First of all, it's a great honor to present my presentation in front of all the dignitaries, all the dignified health administrators as well as clinicians, and all the faculties as well as all the students. So it's a great opportunity for me as a public health administrator as well as practitioner. Uh, I see this as an opportunity to spread more information about my program to all these young, enthusiastic young people over here who are going to work in the field in various different faculties, different professions, and different specialties. But TB is overarching to all the specialties because the TB is a disease which not only affects lungs, it also affects all other systems of the body. So this program is very important to all of you. You will definitely gain something or other from this presentation. I will be talking mostly about the programmatic aspects, the National Tuberculosis Elimination Program that the government is currently following. We had a history of TB programs right from 1962. In 1962, we had TB National TB program at the first, which was the first program for TB. And the first program was basically, it was mainly X-ray oriented. X-ray was the only diagnostic facility which was included in that program. And it was very limited program. Later on in 1997, the next program, that is the RNTCP, that is Revised National Tuberculosis Program. This was the second program and it was a major program. It overarched many other things and it was strengthened further to encompass whole of the nation in 2006. It basically had two major strategies. First was the DOTS, that is directly observed treatment was the first strategy in RNTCP. And next was that the sputum microscopy or sputum examination was the major diagnostic test along with X-ray also. So that was, two major things were included. In further on in 2017, the recent program, that is the National TB Elimination Program or NTEP, it started. This program further strengthens our TB activity and first time the word elimination which has occurred in this program. So now we target, as well as the world targets, to eliminate tuberculosis. So going forward to my presentation. So we all know what TB is. I don't want to emphasize more on the anatomical pathophysiology and the medical aspects. We all know it is basically it is a primary lung infection by Mycobacterium tuberculosis. It is a communicable disease. It's spread by droplet nuclei, aerosols, and primarily it affects lung, but it also affects all other organs in the body. It may occur. It had very historical data is suggestive that it was very, it has been identified long back in various histories, various countries. This slide is very important because the main target of the program is to early diagnose the patients and make them non-communicable by giving them complete treatment. So as we can see here, one infective case of tuberculosis almost has 50 to 20 contacts which are close contacts, and from those close contacts, 2 new cases can be formed, they get the disease. So if we treat that one case, if the case is identified early and is treated completely, the treatment is started, he gets the treatment completed, then the infectivity is drastically reduced. So this is the whole core of the program. We know that it was previously also said in previous lecture that tuberculosis is not only a medical condition or disease, it is more of a social disease. There are many aspects, like we say in our PSM or community medicine, that every disease has agent, host, and environmental factors, that is the epidemiological triad as we say. All 3 components are involved in the disease. Mycobacterium tuberculosis is the agent. Now we have newer agent like we have drug-resistant tubercular bacilli. Then the environmental factors, we all know overcrowding is there. Socioeconomic factors, we all know poor housing, indoor air pollution, all these factors are there. So all the 3 aspects, agent, host, and environment is involved. In agent factors, we know that high-risk conditions like diabetes, diabetes, HIV, and other like the malnutrition. These are high-risk factors. These are agent factors. This is the global TB burden. I think Madam has covered, so I will not go in detail. Only thing I want to show here is that from the global TB burden, around 27% of global burden is from India. So India contributes around 27% to the global incidence as well as the global mortality. So this is our commitment till 2013. The target has shifted now to reduce the incidence by 80%, mortality by 90%, and catastrophic out-of-pocket expenditure. This is catastrophic out-of-pocket expenditure, which is more than 20% of the out-of-pocket expenditure. We have to reduce that to zero. Okay. So what strategies actually we are focusing to achieve this goal in Maharashtra? So the first one is to reduce the incidence. That was in 2015, it was 208. So by 2025, it was supposed to be reduced to 42. We are around 150 currently. So we have not achieved that. We have achieved some progress definitely, but not what we are supposed to achieve. Same with the reduced TB deaths, that there are around 4.47 deaths were there per lakh population in 2015. And currently our district is at 3 per lakh deaths we are having in our district. Last year it was 2. Now we are trying to reduce that further. The key actions that the program is implementing. Firstly is to increase the TB testing rate. So the TB testing is most important because unless and until we screen the population, identify the presumptive or suspects, and test them for tuberculosis, we will not get the TB cases. So that is the most important aspect. Initially we were having in 2023, the presumptive rate was around 1700 per lakh population. Now, as per the program, we are targeting 3000 per lakh population testing rate. So that we can cover maximum presumptive cases and we can diagnose more cases. Second one is the molecular testing strategy. We will further see that what is the molecular testing strategy. These are the newer tests that we are using. Previously, we were using the sputum microscopy as well as the X-ray. But now we are also using the molecular test. We have currently many molecular testing facilities in our district as well. Third is the private sector involvement. In most of the cases, TB cases are also diagnosed at private facilities. And the program now envisions that these all cases should be captured and at least they should be brought under treatment so that no case should be missed. Nutrition part, the program also takes care of the nutrition part because there is a Nikshay Poshan Yojana, that is philanthropic organizations or some donors can give food baskets and act as a Nikshay Mitra. Also, the program from its side gives 1000 rupees per month to the patient so that it can be utilized as a nutritional support. So both activities are act as a nutritional support. Then the preventive aspect of tuberculosis is also focused now because there is a concept of TPT, TB preventive treatment. So the close household contacts of TB patients, they are given treatment or preventive treatment so that because they are at high risk of contracting TB from the close relative in the house. So that is also focused, we will see that later on. We all know the presumptive symptoms of TB. I will not go into detail. We know that more than 2 weeks of cough, more than 2 weeks of fever, evening rise of fever, blood in sputum, weight loss, all these things we all know. These are constitutional symptoms which are mostly seen in TB and we focus majorly on these symptoms. These are the high-risk people. These people need to be screened more vigorously. Even a single day of cough is seen in these people. The patient can be screened for TB in that case. For like patients with HIV, diabetes, malnourished, or microbial contacts of microbiologically confirmed TB case, or patients for immunosuppressive therapy. There are also extrapulmonary cases, as we all know. It does not affect only lungs, so extrapulmonary cases also are also there. And the presumptive definition is in these cases depends on what extrapulmonary site the TB is located at. Means if there is a lymph node TB, then there is a swelling of lymph nodes. If there is a tuberculosis of the bone, then there is pain and joints swelling is there. So it depends on what site is infected or affected. And plus there are constitutional symptoms also. Pediatric TB is means actually the constitutional symptoms are same, but there is some twist to the symptoms. Like there can be persistent fever or cough, but it is not always present in every case. Sometimes it is also possible that only there is weight loss or inability to gain the weight, as we see in the malnourished children. It is mostly that they have inability to gain the weight. The weight does not increase as per the standards. So that also can be a presumptive pediatric TB case. And the presumptive DRTB case. Now we will see further that we are following UDST model. That is, every TB case has to be tested for susceptibility, whether they are susceptible to the antibiotics or treatment given. So presumptive TB case, presumptive DRTB or drug-resistant TB case, we are supposed to have if Wills means all the notified TB cases which are microbiologically confirmed. We test them for resistance, and they are the presumptive. Also the follow-up cases means we take sputum examination follow-ups for all the patients at 2 times in the treatment interval. And all the 2 times, if the result is positive, they are not responding to the treatment, then we test them for the drug resistance. And also clinical non-responders who don't respond to the treatment. Any type of surveillance, in public health surveillance, we follow 2 types of surveillance. First is active surveillance and second is passive surveillance. In active surveillance, the patient is traced at their home and in their communities. Means our ASHA workers, health workers go to house to the patient and see if they have any symptoms or signs of tuberculosis, and they then take their sample for testing. The passive surveillance is very easy. It is done in all the hospitals and health facilities. Means patient, he himself comes to the hospital, and if he has any signs or symptoms of tuberculosis, we take his sputum for examination or we do the X-rays. So in any health institution, we supposed to have that 2 to 3% of their adult OPD will have chest symptomatic patients. And these chest symptomatic patients need to be tested for tuberculosis. So this is very important so that no case can be missed even from our hospitals. This rate actually is much more in secondary and tertiary institutes like this hospital also. It can be more than 3% also. So it has to be focused in future also so that no case is missed. So I will not go into detail for this. Now coming to the TB diagnosis, as sir has rightly said, the tubercular bacilli was identified first in 1882 by Dr. Robert Koch, and it was at around the 1880s and 90s only the first diagnostic technique, that is the ZL staging and microscopy, was devised for diagnosis. Later on we have developed many more techniques. This is the ZL staining technique and the microscopy, the tubercular bacilli and acid-fast bacilli. Then the chest radiography, X-ray technique or radiographic tools are there. These are actually used as an adjunct to the microscopy now, and these act as a tool to increase the sensitivity of our diagnostic techniques. So X-ray will improve our sensitivity of testing and give more cases to us. So it is now as an adjunct. So any case which has done sputum microscopy also undergoes X-ray now. So this is the technique and everything how to get the samples and all. Most important thing is in this is the sample has to be of good quality. My previous slide also suggested that the sample should be mucoequivalent and the slide positivity should be range about 5 to 15% so that it is positive. It is good quality. these are the recent tools that I was saying. These are the gene expert or CB9 testing as well as the TrueNAT testing. These tests are now incorporated in public health also and in our district. Now we have almost 3 CB9 machines functional as well as 21 TrueNAT machines functional in our district. The CB9 machines require some good laboratory facility, air conditioned facility, temperature control has to be there, so they cannot be located in peripheral institutions. But the TrueNAT testing, it is an indigenous system and it can be located at periphery, even at subcenter level also it can be placed and it can be utilized. So it is an indigenous process and it is a very good test with a very high sensitivity. So it is written that 40% more sensitive than the sputum sphere microscopy. And as per the program now, this test, that is CBNAT and TrueNAT testing, is offered upfront. Means any case which has come, which is symptomatic, is tested for CBNAT and TrueNAT now. So it is an upfront test which has been offered now. Results are available within 2 hours. And also one more advantage is that along with the testing, along with the diagnosis of tuberculosis, it also offers whether there is a resistance or not. Rifampicin resistance is also diagnosed in this. So the NTP current policy about NAT is that all the symptomatics are to undergo upfront NAT now. So every patient undergoes NAT testing. Along with if the diagnosis is made by smear microscopy only, then in that case the sample has to be again undergone to the NAT testing, so that rifampicin resistant testing has to be done. This is the diagnostic algorithm. I won't go into detail. Only thing is here, what I want to show is that any presumptive TB case undergoes smear examination as well as the chest X-ray. So it is an adjunct test. Chest X-ray is an adjunct and it can improve the sensitivity of the testing. Universal drug susceptibility testing is now done. Any microbiologically confirmed TB case. Here, microbiologically confirmed means any case which is diagnosed by either smear microscopy or by the CBNAT testing. All the cases now undergo DST, that is drug susceptibility testing. So the first testing under DST, drug susceptibility testing, is for rifampicin, which is the most common type of resistance observed, and it is done by our CBNAT and TrueNAT machines. This is the first test. If the test is positive for rifampicin resistance, resistance is found. Then further testing by first line LPA, that is line probe assay, that is done at our lab at Pune. And further, if even first line it is positive, the fluoroquinolone resistance is found in first line LPA, then further other direct testing in second line LPA is also performed. We will be seeing this later on. So no patient is left out from the universal drug susceptibility testing. The same is shown here. The first line LPA, it detects basically the rifampicin and INH resistance. The second line LPA detects basically the fluoroquinolone resistance and the second line injectable drug resistance. And the MGIT, that is liquid culture, that is also used to find the resistance. That is also available at the divisional level, Pune level facility. So this is the algorithm that is followed basically. It is very simplified algorithm. So NAT testing is done for all the patients. In the NAT testing, if there is rifampicin resistance is found, then first line LPA and second line LPA are performed. And accordingly, what resistance is found, accordingly we go for the regimen for treatment. And if resistance for rifampicin resistance is not found, then also we do the first line LPA and see for whether there is INH resistance or not. If INH resistance is there, then we again have another therapy for that. We will see that further. So all the TB cases are basically categorized into pulmonary and extrapulmonary first, and later on microbiologically confirmed and clinically diagnosed. So these are the definitions. Microbiologically confirmed case is any case which is either diagnosed by NAT or smear microscopy. and any case with the clinician diagnosis on the basis of X-ray or clinical suspicion, but is not microbiologically confirmed, we say that case as a clinically diagnosed TB case, and we can start that also on treatment. So based on the sensitivity drugs, we categorize the TB in the program as drug sensitive and drug resistant. We will see types of drug resistance later. These are the first line drugs. Basically, these drugs are used for in the program for drug sensitive TB. First four, the last one, streptomycin, is now omitted from the drug sensitive TB regimen. Isoniazid, rifampicin, pyrazimide, and ethanol are currently used. This is the regimen that we currently follow. Ours is a 6-month regimen with 2 months of IP and 4 months of CP, that is continuation phase. Previously, it was an alternate day regimen, but now we follow daily, FDC daily regimen is followed. Daily drugs are given, and it is a fixed dose combination. Means all the drugs are included in the same tablet. It is a fixed dose combination we use now. It is a weight band based treatment now. Means the treatment is basically given as per the weight of the patient. So as per the weight, this chart shows as per the weight how many tablets the patient has to take. Same FDC formulations are also prepared for pediatric patients, and there is also a weight-based system for that. These are the total drugs which are included in the NTP program for tuberculosis. Various other different combinations are made according to the susceptibility of the patients. Only thing I want to focus here is that the two drugs, basically the delaminid and the bedaquiline, these drugs are basically used only in the public sector. Private sector does not have these drugs, and these are only used for multi-drug resistant cases, especially in the government sector only. These are the various definitions of, I will not go into the detail of the multi-drug resistant regimens. And this is the diagnostic protocol, okay. Basically, there are 4 different types of regimen used for the multi-drug resistance or drug resistant TB currently. First is the H-mono or poly-DR TB resistance. This is the regimen used for INH resistance, isolated INH resistance. If it is there, then this regimen is used. The second one is the BPAL regimen. This is the bedaquiline based regimen. BPAL is a regimen. This is the most commonly used regimen now currently for all the drug resistant TB cases. Third one is the shorter oral bedaquiline containing regimen, and the longer one is also there. So the treatment, basically all the multi-drug resistant or DRTB cases now get 6 to 9 months treatment. In exceptional cases only, the longer regimen is now considered. So follow-ups of all the cases are done. In drug-sensitive cases, two times follow-up is done at the end of the IP and at the end of the treatment. Even after treatment completion also, the follow-ups at 6, 12, 18 and 24 months is followed. Now we all know that TB infection is very different from TB disease. TB infection is only occurrence of the bacilli in the body. It does not cause any pathogenesis or it does not cause disease. But the TB disease is a different. The bacilli form show their pathogenicity and the disease is formed. So these are both different entities. We all know that around 70 to 90% of population is already infected with tubercular bacilli. Only when the immunity is suppressed, the infection is converted into a disease. So these are two different symptoms, different entities. Now, currently the program has a component of TPT. TPT means TB preventive treatment. So basically this is giving preventive treatment to all the contacts, close contacts or household contacts of microbiologically confirmed TB cases. So all the microbiologically confirmed TB cases, their contacts are searched, household contacts are searched. They are screened whether they have symptoms of TB. If they have symptoms of TB or they have shadows in their X-ray suggestive of TB, then they are diagnosed for TB or they are tested for TB. If they don't have any symptoms, they don't have signs of tuberculosis, then they are giving the TPT, that is the TB preventive treatment. So it is basically to eliminate the TB infection that they are having, because they are very high risk to contract the TB infection as well as the TB disease, as they are in a very close proximity of the patient. So basically we have two main regimens for TPT, that is TB preventive therapy. First is the 3HP, that is 3 months of weekly isoniazid and rifampicin that is given. And the second one is for 1 HP, that is 1 month of daily 28 doses of isoniazid and rifampicin. So these two are basically used. The third one is not commonly used now. These two regimens are mostly used now as a TB preventive treatment. One more thing, the NTP program now says, that is differentiated TB care. Basically, we are saying that we have almost 3% of TB mortality now currently. Last year we had 2%. But even that is higher, on a higher side. We want to prevent that mortality. And most of the mortality in TB patients is not only related to tuberculosis. It is also related to other comorbidities, other physical conditions that lead to the morbidity of that patient. So differentiated TB care is a drive, or say it is a component of the program which deals with that. Whenever the TB patient is diagnosed with TB, all other physical parameters tests are performed for that patient. So to see whether he has any other physical condition or comorbidity associated and whether that can be treated. So we have almost 16 different parameters which are tested for or looked for. And according to the 16 parameters, the TB patient is categorized as per his risk scoring for that patient is done. And accordingly, whether he is either treated at that institute or referred to some higher institute for treatment of the associated illnesses also. One more thing, that what are the various types of benefits the patients receive as well as the treatment supporter receives. Because TB, as we say, it requires multi-pronged approach. It does not require only medical approach. And as we see that most of the cases are from lower socio-economic status also. So nutritional support is also very important component. So government gives as allotted around 1,000 rupees per month for whatever the duration of treatment is there to the patient as a nutritional support from Cme Yojana. So that is one component. The second one is the treatment supporters honorarium. As I said, that DOTS approach is used in tuberculosis management. The treatment is fully supervised and the health provider provides the treatment in front of him. So the treatment supporter is also given incentive. That is 1,000 for DSTB and around 5,000 for DRTB patient is given to the treatment supporter. Then notification means incentive is also given to a person who is notifying the case. If any private practitioner notifies any TB case, or any chemist, or any lab technician, any private lab notifies the TB case, he is also given an incentive from the government. 500 is given as an incentive for notification and further 500 for treatment declaration. That is, if the treatment is supervised and the treatment is completed at the institute or hospital or anywhere. So that is also an incentive. Further, if the TPT is started and it is supervised, then the community worker or ASHA worker also gets 250 per patient for a TPT, that is TB preventive treatment. Various other initiatives also are taken care of in the program, as this is a very social components are also there in this disease. So various other components are also included. Community mobilization component is also very important. First is the Pradhan Mantri TB Mukta Bharat Abhiyan, as Madam had already said, 100-day program. 100-day program was launched in November 24 and last year in December it has finished. But now part 2 of that program, second phase of the program is launching today only. So in that phase, all the vulnerable group populations, along with the population from hotspots or high-risk areas, high-risk villages, above 40-year population is further going to be screened in that program. So that maximum screening of the population is done. TB champions or TB survivors, patients who have undergone TB, those are to be identified and those are to be utilized to make advocacy, go into the community and do advocacy about the disease, about the treatment part. So they are identified and it has been going on. TB-free Gram Panchayat initiative. As we all know, it is a very social problem also. And the local bodies like Gram Panchayat, urban bodies also need to take initiative in TB campaigns, TB preventive activities, advocacy activities. So TB-free Gram Panchayat initiative has been taken by the government. And there are 6 indicators have been identified. All the Gram Panchayat in the districts in the state undergo these 6, they are evaluated on these 6 indicators and their ranking is done in the state. If they are qualified, then they are also given prizes for that. This is the TB gathered for TB notification. We all know that now TB is a notifiable disease and every private organization, every doctor, everyone has to notify a TB case if he has diagnosed or if anyone is taking treatment at his center. So it is now TB notification is compulsory as per the government guidelines. This is a web-based portal and all the data related to the tuberculosis or NTP, right from the presumptive case, diagnosis, treatment initiation, follow, everything is web-based and is entered in Nixche. So nothing is on paper now, everything is on web portal only. This is Nixche Setu app. This is basically a e-learning platform for capacity building of our health staff and doctors. So it is a government initiative, all information related to tuberculosis diagnosis, treatment, everything for health providers is provided on this app. And the second one, this is one for the patients and the community. That is TB Arogya Sathi app. The patients and the community can gain more information about tuberculosis from this app. So we all know that tuberculosis now, as we have said, it is a preventable and curable disease. But yet it is a major public health problem in our country. And so we all need to focus. So this is our, as the slogan for the TB Day today, that yes, we can end TB led by government of Maharashtra and powered by Jan Bhagidari. Because we all know Jan Bhagidari or public involvement, community involvement is a very important aspect if we want to end this TB. And so we all need to go forward with it. Now this is a tertiary institute and as we all know that all different types of it is a multi-sectoral approach and we all require to work together to end this TB problem. And as a health administrator, I also feel that the public entities or tertiary private institutions are also very good partners along with us and we together can end TB, definitely end TB by 2030. So looking forward, I think this was a very good opportunity for me to present the program. I think students might have gained some aspects regarding the program. Hopefully seeing for better partnership in future also. Thank you.